Welcome to another episode of Brain Buzz, where we delve into the fascinating world of neurosciences and brain health. I'm your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen.
Well, we're very excited today. We're going to have our first guest for our podcast. We're welcoming Dr. Ahmad, Dr. Javaad Ahmad, one of my partners in the hospital and a neurologist by training, and currently the director of the neurointensive care unit at Good Samaritan University Hospital. Javaad, welcome.
I appreciate it. Thank you.
Thank you for coming.
Oh, thank you for having me.
So, our topic today is carotid disease and all the treatments that we have for carotid disease. And we thought, what a better person to come and talk to us a little bit about the medical side of carotid disease than Dr. Ahmad with all his experience in neurology. Right, Jason?
Yeah. I mean, we do a lot of carotid patients, and you receive them for the aftercare, which is some of the most important care. So You're a very critical piece of this whole thing.
Excellent. And Javaad, just for our listeners, can you tell us a little bit about yourself and kind of what brought you to Long Island and what you're doing in your everyday life?
So I was actually born and raised on Long Island. Yeah, born and raised on Long Island. I wanted to come back to Long Island after my training. I did my training in neurology at Seton Hall University in New Jersey. After the training, I realized, neurology was a great segue into what I wanted to do, which was neurocritical care.
Okay.
So I went to Mount Sinai, did a two-year fellowship in neurocritical care. And then afterwards, I heard that Dr. Bekelis is coming from Dartmouth. And I decided to, interview around Long Island, and, Good Samaritan's been my home ever since.
Oh, well, thank you for heeding the call.
I think the past 7 years we've been working together almost now, right?
Yeah.
Absolutely, yeah, almost for 7 years. And Javaad was one of the first people that came to start the program. And, for you guys that are not familiar with kind of the beginning of a center in medicine, it's a very daring step, right? It's extremely unknown. It's a service that's not provided locally. And then to come and put all your energy it takes a special person, some early adopters, and certainly I think Javaad was key in that.
I think when I interviewed there, it was the ICU was still an office unit.
That's right.
I was going to ask that if it was even existed when you came.
No, it didn't.
So you really believed in the vision.
Oh, 100%. 100%.
As a matter of fact, when Javaad started, they were building the neuro ICU, and we were sharing space with a surgical ICU, so he would run across the hall and round on these patients with the APPs. There's a lot. Another thing that we rarely talk about is the training that went into this, right? And so when we started, nobody really knew much about what we do these days, and today it's a reflex for everybody, right? So Javaad had to train the APPs, the advanced practice providers. He had to train the nurses, and so he did a lot of that on the fly, even without a real unit yet in existence.
So you're a real cornerstone. Thank you.
I wasn't the only person. Dr. Bekelis was there. He was there for...
I was there for a different thing, but
since the inception.
I would say the ICU would not have been done without you. And most importantly, so in Suffolk County, when we started, there was no other neuro ICU. There were corners of taking care of neuro patients in different units, like surgical ICU or anything else, but that was the first neurointensive care unit that was created, and thank you for being there for it. Excellent. Well, very exciting person to have with us today, and so let's dive right in on carotid disease. So carotid disease obviously is very prevalent. You guys hear a lot about it, and so a lot of the questions we get in the office have to do with the nature of carotid disease. What is significant about carotid disease? What is plaque buildup or atherosclerosis in the carotid? And maybe, Javaad, you can shed a little light on that.
So we do know that the higher someone has cholesterol, high cholesterol someone has, the bad LDL that we call it, the higher predisposition somebody has for plaque buildup. Mm-hmm. Now, plaque buildup does not only happen in the carotid arteries; it happens throughout your body.
Right.
So it's not only the brain; it's the heart, the brain. Mm-hmm. All your vessels. So
and always when we see these patients, right, they have peripheral vascular disease, heart disease. It's extremely common, and so for our listeners out there, if you have been diagnosed in the past with heart disease, you've gotten stents or peripheral vascular disease, there's a very high possibility that you'll build up plaque in your carotid.
Absolutely.
So where does the plaque come from?
So, there's multiple theories about the mechanism for plaque creation and atherosclerosis. At the end of the day, it's some sort of injury on the vessel wall that then the local flow dynamics propagate, and you have more and more deposition of calcium and inflammation and atherosclerosis and cholesterol, and eventually there is an enlargement of that injury that causes blockage in the blood vessel wall, and the blood vessel has a harder, or the blood has a harder time going through that blockage. And the significance of it is not so much, that's another misconception, I think. The significance of carotid disease is not so much the decreased blood flow into the brain, the decreased supply of blood, so to speak. It's more so the fact that as the plaque gets more significant, it's more friable. It can break off, it can go into the brain and cause a stroke.
So again, exactly that to the pathophysiology of it, just like Dr. Bekelis said, it's probably, I guess, the easy way to think about it, the higher cholesterol someone has, the easier that these cholesterol deposits can kind of lodge into those arteries. As a result, these arteries then have cholesterol deposit. Then they're also, because there's cholesterol there, it's predisposition to have more things to kind of just jump onto that cholesterol, that being fibrin, that being calcium. And as a result, if it gets too big, right, we all know that equation where you have higher diameter of something, it's increased ability to be more friable as a result, increased ability to kind of pop. That's what happens.
Right.
So that's what happens with a lot of strokes that we see. Right?
So when you say cholesterol, you do mean that, like, when the normal person thinks of cholesterol, it's the burger I'm going to eat or that fried chicken I'm going to eat.
Right, and a lot of it is genetics, and maybe Javaad, correct me on this one, but my understanding is that the majority of your risk from cholesterol and elevated cholesterol comes from your genetic predisposition to these diseases, and of course diet is important, right? But it's not, maybe not the prevailing factor. Of course, if you have the predisposition, you'll develop the disease. You can help with the diet, but it's not the one only component that we think about. I don't know what's your thought on that.
No, absolutely. I think just besides the diet, physical activity, the things that we all know about are quite important. But the things that we can't control, genetics, your ethnicity, right? These are non-controllable risk factors, and they play probably one of the most important factors, or the most important factors. Since they're non-controllable, we focus on the controllable risk factors. So we focus on making sure your blood pressure is at a decent level. We make sure that your cholesterol level is a decent level. We make sure that you're exercising at least 3 times a week, 30 minutes a day. These are all really, really vital, important aspects as to decreasing your predisposition for stroke or heart attacks or any type of cholesterol issue.
Right, and that's very important, right? Cardiovascular disease is cardiovascular disease. It's carotid, it's the heart. So if you control the risk factors for any of them, you will be in a good spot in terms of your overall cardiovascular risk. And certainly, a question that we get a lot also is, what's the ideal, say, blood pressure? What's the ideal? But what we tell people is, everybody's individualized, right? And work with your primary care doctor, and they'll get you to the right level. I assume that's the general recommendation, right?
I think from our point of view, from a neurocritical care point of view, and that's what we do, right? We work in the ICU, we work in the hospital from a neurological perspective. There are different guidelines out there from American Heart Association that, they give you some sort of guideline where your blood pressure has to be below 120/80, right?
Right.
But we also know what we see every day from anecdotal experience, like every patient is different at the end of the day.
Right.
Every patient is different, and you have to cater it to every patient, right? Like, say someone has a LDL of 200, which is off the charts, right? 200, 250, off the charts. Their best LDL, if they get down to 100, that's really good for them, right? As we say, patients who have strokes after a stroke, like secondary prevention, would be to have LDL less than 70, right? You guys see that, right? But if you can't get it below 70, then you have to focus on the patient itself, right? The lower the cholesterol, the better for the patient at the end of the day, right? We have this mantra in the neuro ICU If someone's cholesterol is even 70 or 65, bring it even lower, because at the end of the day, having low LDL, when I speak of cholesterol, I speak of LDL.
Right.
When we have a mantra saying, bring the LDL as low as you can. If you could even bring it to the teens.
Right, right.
Having a low LDL does not harm the patient, as for most studies say. Having high LDL, on the other hand,
a problem. What's good cholesterol? You know, a lot of patients are like, oh, my good cholesterol this and my good cholesterol that. What's that?
that's HDL. Right?
Okay.
That's the HDL. And usually there's also an equation about LDL minus HDL. You want your HDL to be high. You
Okay.
know? Some patients, again, and also mostly in female patients, and also deals with genetic variabilities. But the higher the HDL, higher than 45, 50, that's good protective cholesterol. You know, that combats the bad cholesterol.
Right, right.
It's in layman terminology. You know?
Right. No, that's spot on. Yeah. And what about diabetes? What's the role of diabetes in carotid disease development?
Diabetes they work hand in hand. That's what we're also kind of alluding to. You know, it's not just the blood pressure,
right.
It's not the cholesterol, but you know, there's something that's very important is diabetes, because at the end of the day, these cholesterol deposits also kind of work. Coincide with how high your glucose is and your
right.
hemoglobin A1C, and how well you're controlling your glucose levels, right? We see it every day, right? Even patients with amazing cholesterol, amazing blood pressure, but just being diabetic in itself,
right?
With a hemoglobin A1C off the charts, these patients come in with thrombotic strokes, with local strokes because of atherosclerosis in the brain, and the same thing with the heart, right?
Right.
And that's if everything is even accounted for. Everything is great except the fact that the patient's diabetic.
Right.
And usually when you're young, it's usually because it's type 1 diabetes, and you have a high genetic predisposition to it.
Right. What about smoking?
Smoking, absolutely. Dr. Bekelis, maybe you can tell us more about that.
Well, you know, I mean, on my perspective, obviously, any cardiovascular problem, smoking makes it worse. Even in isolation, even if everything else is very well controlled, smoking puts people in a bad spot. And you know, the same thing applies for carotid disease, of course. But also when you have these risk factors, the impact of the combination is a lot more than every risk factor individualized. You know, smoking and diabetes or smoking. And, you know, we had developed, kind of a shameless plug, but we had developed back in the day a predictive model for carotid disease. And we had published those results where we looked at your risk of a bad outcome from carotid intervention or from carotid disease. And, you know, having individually just smoking or high cholesterol as a risk factor was a lot less than having both. Having both was a multiplied impact of your risk of stroke down the line. And that's what we worry about with carotid disease, guys. We worry about the risk of stroke. That's the downstream effect of having carotid disease. Carotid disease in and of itself, you know, it's inconsequential, doesn't really change much in the way somebody feels. Symptoms is a stroke or a TIA, and you know, and on that aspect, is there a way to detect carotid disease before it becomes symptomatic? Are there warning signs and symptoms, or is it one of those things that you randomly discover it and you have to do something about it, or after symptoms come on? Or is there something that our listeners can look for to prevent this from happening?
I just want to make one point, just kind of like hammer this down, because I think it's so important, like the modifiable risk factors. Because what you just explained, this list of cholesterol, diabetes, smoking, these are modifiable risk factors, right? These are things that we can take care of as best as possible, right?
Right.
So we have to, it's like incumbent upon us, incumbent on your listeners as well, to try to, you know, go to your doctors, see them at least once a year, get your blood work done. These are important things. And if you're smoking, try to quit. Try to, you know, if there's programs that can help you to quit smoking, or vaping now, and vaping is huge. I think we have to touch upon that.
Yeah, actually, what's your take on that? You know, people say, you know, I'm not smoking cigarettes anymore. I'm just vaping. So, or they're smoking marijuana. Does that have the same effect on cardiovascular health?
So I can't speak for marijuana per se, but if vaping's anything like smoking, and I think it is, I think there's always going to be a deleterious effect to the body. Right. At the end of the day, we're trying to live our healthiest lives and our best lives, right? So just having everything in par with your physical health is quite important. And vaping's probably not the best thing to do, based on what I think.
Right.
Yeah, no, it's not good for your body. And then
Vaping
I've also
industry
heard
probably
stories.
does not like what I'm saying right now.
But I also heard stories of them blowing up in your pocket. So there's an added risk to that.
There you go. They blow up in your pocket too. Why else would you want to smoke?
I think they should still subscribe even if they don't like what we say.
Exactly, right?
But so how important is it to know about carotid disease before it causes problems? Say you find out about it for whatever reason, right? And maybe it's mild, maybe it's moderate, maybe it's significant. And by the way, when we say significant, there are some percentages of blockage in the carotid artery that make something significant, and that kind of goes hand in hand with how friable the plaque is. But say it's not significant yet, it's mild or moderate. Is that important, and why is it important for somebody to know that they're developing this cardiovascular disease?
I think we're probably all on the same page when it comes to this, because we work in the same field, and we all think at least I think it's quite important, right? In order to kind of predict future outcomes on any patient or at any level, you have to know where you are at baseline, right?
Right.
So your baseline is quite important to establish, just like we were talking about. You have to see your primary care doctor. So if your primary care doctor, say, all of a sudden orders a carotid ultrasound, check the velocities, or they do some type of test imaging.
Well, that's what I was going to ask. What kind of, if I go to see my primary, I'm worried about this, I have a genetic disposition for it. What are some of the tests that I should be looking to undergo? So
that's one thing. Let me just finish up. So what Dr. Bekelis said, I think, is an important point, right? Even if you're at 10% of a cholesterol buildup, you have to follow that up.
Right.
What about a year from now, if you're not eating right, your diabetes is 30%.
Right.
Then it gets to 50%. Right?
Then all of a sudden you have a stroke.
And then all of a sudden you have a stroke or some type of watershed stroke, and that's some semantics. But I think Dr. Bekelis is probably the best person to ask for it in his clinic. I mean, they do surveillance there.
Right. We monitor patients with carotid disease. We monitor them with ultrasound. The way you do it is with ultrasound. Ultrasound is a non-invasive way to monitor things. There's no incision. There's no needle stick. You get very good general idea of how severe the blockage is. Now, if it's on the mild to moderate category, you monitor it, right? You work with your primary care doctor to control those modifiable risk factors. Those modifiable risk factors can prevent 80% of strokes. It's amazing to think how many fewer strokes we would have if we were to control these modifiable risk factors, right? We love what we do. We love to fix stroke, but we would love to get out of business by controlling these risk factors. But unfortunately, it's not happening as well as we would want it to happen. But so when we see that carotid disease buildup, we control these modifiable risk factors. We prevent it from building up any further. But in some cases, it'll be significant. And then there's another conversation about what you do to prevent a stroke in the setting of significant carotid disease. And what are the tools that we have there for, in terms of surgical interventions or other stuff.
Can you go into that a little bit more?
Yeah. So there are generally speaking 2 general ways to treat carotid disease, and Javaad and I deal with that on a daily basis. And there's the kind of the open surgical procedure where we make a skin incision and remove the plaque from the carotid artery. We practically scoop it out, and that's called a carotid endarterectomy. It's a very old procedure, one of the oldest surgical procedures we have, and a very good surgical procedure. But it's an open surgery, right? It's not minimally invasive. The alternative to that was the stent, and the stent through the groin or through the wrist, through the artery in the groin or the wrist. We navigate our catheters and wires into the brain, and we place the stent across the area of the blockage after we've stretched it open. Now, the thought process with the stent that made the stent not as attractive as the carotid endarterectomy is that you were crossing a blocked area without a lot of protection. So in theory, you could knock off some sort of plaque or debris from that area and send it into the brain and cause stroke during the procedure. That risk was very small, but certainly higher than the risk of that happening during an endarterectomy. So we came up with a hybrid procedure, taking advantage of the benefits of both procedures, the safety of carotid endarterectomy and the minimally invasive nature of a stent. And that procedure was called transcarotid artery revascularization, or TCAR for short. And TCAR is a great alternative to the other two procedures. It's a stent which you place in somebody's carotid artery through a small skin incision, about an inch long, just above the clavicle, and that's your access. But the benefit of this procedure is that you're reversing the flow during the procedure to remove all the debris out of the body instead of obviously sending it into the brain. Really impactful interventions, I think. And, I think there's been a shift definitely locally from the more invasive procedures into TCAR, and I'm sure you see it
I see it
in
all
the unit,
time.
right?
When you were talking about it, I was excited that you brought it up because it's absolutely the case. After taking care of these patients in the ICU in the past, I don't know how long have you been doing it for?
About a year and a half.
About a year and a half.
Right.
We've seen great outcomes.
Right.
And we haven't seen that shower of stroke that possibly can happen with a stent,
Right.
Just great outcomes.
What's the stay like between all of the treatment options?
Actually, it's very similar. So we keep folks after carotid intervention for a day, right, in an intense setting like the ICU, but it's mainly for observation.
Yeah, and the observation is important too. The first 24 hours are crucial. Like even though they stay for the day, we're watching their blood pressure. The biggest complication, the harshest complication, and I'm not sure if your listeners ever heard, but reperfusion injury.
Right. Tell us about that a little bit.
Absolutely, super important to make sure that after the carotid intervention, because at a point, right, you have a carotid artery, normal size, probably this big, right?
Mm-hmm.
It gets stenotic, 99%, 97% stenotic. You're opening it back up to a full 100% open, right? What happens? It's a hose, right?
Right.
It becomes a plumbing system.
Right.
All that blood flow will shoot into the brain. So
Right.
it's super important to have the blood pressure at a decent level. When I mean decent level, at a lower level than normal. Okay, if the patient's walking around at 160 because they're autoregulating,
Right.
meaning they're pushing all that blood pressure through that small artery for years,
Right.
and then all of a sudden you open it up, you're hoping that the patient doesn't have this reperfusion injury, which basically means a rush of blood to the brain. And especially if that blood pressure continues to stay up post-procedure, that can be very deleterious as well. It can be very, very harmful for the patient. So when they come to the ICU, Dr. Bekelis and I, we speak about it, and we have blood pressure parameters, very, very tight blood pressure parameters so that the patient doesn't have that rush of blood. Because when you do have that rush of blood, and unfortunately it may happen here and there. We've never had it, thank God, and knock on wood, never had it happen. But, reperfusion injury can be as horrible as putting someone to coma.
Right.
Right? Coma, seizures, these are really, really bad things.
Yeah.
And sometimes patients don't wake up.
Yeah, it's like flooding a field that's in drought. And, obviously they cannot absorb all that water. But if that's the role of the ICU, that's why it's
it
important.
goes to show you.
Yeah, it's
you
important.
You always say that, we do what we do, but it's really on the back end that
Right.
makes a huge
I keep
difference.
saying this, and it's the truth. We're glorified plumbers. We'll fix the problem. But what happens on the back end is really what makes the impact on these patients, right? If the critical care is not good, you're going to have a situation where the procedure is perfect, but you have a complication afterwards. And that speaks volumes to the quality of the critical care at the Stroke and Brain Aneurysm Center of Long Island, that we really don't see these issues because folks are very attentive and they know what to do. They know what to look for. But certainly very challenging overall for patients. Blood pressure is a big thing when it comes to carotid disease afterwards. They might be too low, might be too high. We're affecting a lot of the normal regulation of blood pressure by those interventions. So I think having somebody like Javaad and the team out at the Stroke and Brain Aneurysm Center makes the world a difference.
for sure.
Absolutely.
And the ICU rooms are really nice too.
Yes, of course.
It's like a suite.
I know, for real.
It is a suite, but that's not your incentive to fix your carotid.
No, but it helps to stay.
But I do tell
Family members, they stay another extra day or two.
For sure.
I do tell the patients that they get a private room when they're. That's the other thing. Carotid disease, it doesn't hurt, right?
No.
Heart disease, it hurts. People are feeling angina. They're miserable. They go to the doctor. With carotid disease, sometimes it's tough to convince people that they're going to have a stroke if they don't address some issues like that. And so, I think the private room is an added incentive for some folks.
For sure.
And so do we have some questions to because we don't have we're trying to keep these podcasts to about 30 minutes. Just to keep your attention, guys. And so we're looking at the time now, and we have about 5 more minutes, so maybe we go to the questions that you guys sent us just before this podcast.
Absolutely. I think this is a great question because you all touched on the risk factors, but can carotid artery disease be prevented entirely, or are there only ways to manage it once it's diagnosed?
Entirely, so you never have carotid disease,
That's what
right?
I'm looking for, yeah.
I think that's what Javaad said. I mean, if you're able to do your regular checkups with your primary care doctor, and you're able to really address the risk factors, the possibility of developing carotid disease is small. Entirely, no. Even if you control 80% of the risk factors and you never develop high blood pressure, cholesterol, diabetes, or if you develop them, you address them. Because of course, there's no such thing as I'm never going to get high blood pressure. There's folks that are young, healthy, exercising, and have high blood pressure, right? And so, but even if you develop them, you control them. There's still about a 20% genetic predisposition component that you have no control in, but follow with your primary care doctor. They'll be able to guide you and identify issues before they develop. But yeah, there's no perfect and absolute prevention,
so
unfortunately.
Basically, if you're able to play genetic dodgeball and
Correct.
win, and then just monitor the controllable factors, you should be okay.
Yeah, that's right.
Good. Another question we have is carotid arteries primarily age-related?
Yeah, I think. I mean, what do you think, Javaad? I think we see it more often in the elderly, right?
Yeah, I mean, as you grow older, right, these risk factors that we spoke about, they become more, I guess, dominant in one's life, right? And as a result, we see it in older patients. Plus, we see a lot of calcification. As you grow older, you have a lot of calcification in the body. That just shows that there's cholesterol deposits there, and they calcify.
Right, and I think actually that's an interesting point. There's studies out there that have shown that even in young folks or in children, there's cholesterol starts to get deposited in the blood vessels from a very young age. But the process is not a process that takes a year or two. It's a long process. And that's why you see it mostly in the elderly, because that kind of gets piled on over time. And that's also another important point. Don't start taking care of yourself when you're 40, 50, 60, because now is the time for carotid disease, right? What you've done in your 20s and your 30s will have an impact in your 60s and your 70s. So, you only get one body, take care of it, and don't wait until very late in the game. You'll be playing catch-up at that
40
point.
is not that late, all right?
Listen, we're all in the same boat. 40 is perfect.
And we all know when you're 18,
40 is
19,
the new,
20,
40
you're
is the new
invincible.
18.
There
yes.
you go.
Yeah. No, and you're invincible when you're 18, 19, 20. So
correct.
You're not going to worry about
We're all
carotid
faced with our
artery
mortality
disease.
now, yes.
So I have one from a patient that was actually treated.
Okay.
Is there a possibility of recurrence after treatment, and what should I be vigilant about?
Yes, there is a possibility of recurrence, and recurrence happens either because the risk factors are not well controlled or because of genetics again. And there can be recurrent blockage of the carotid artery. The chance of needing treatment for that recurrent blockage is very, very low, extremely low. Most of this recurrent carotid disease is not atherosclerotic in nature. It's mostly reactive, meaning the body reacts to the treatment you did, and it kind of tries to seal the area, and sometimes it does it in an excessive manner and creates a new blockage. And those tend to not cause strokes. They're not as friable. They're not as dangerous. They're not as inflamed. So those, we don't really necessarily touch. And majority of the carotid we treat these days is symptomatic, meaning it's caused a stroke or it's caused a TIA. And if you guys want to listen more about stroke or TIA, our first podcast, we discussed that quite extensively. But so unless you have symptoms, these generally do not need treatment. We monitor them. So, if you get a stent or you get an endarterectomy, we'll monitor you for a very long time, every 6 months with an ultrasound or every year, and then we'll see if there's any issues. But certainly the chance of recurrence is there, and sometimes we have to treat it.
Mm-hmm. Good explanation and good plug for our previous podcast.
Always working.
That's right. How can I best manage and minimize the risk of complications following the treatment of carotid artery disease?
So after treatment, when you leave the hospital, the possibility of complications is slim to none. Things that you need to stay on top of are the medications that you've been put on. So if you say you've had a stroke or a TIA, we found that the cause is carotid disease. We fixed the carotid. Now we have to make sure that all your risk factors that led you to that point are controlled. So that's what you need to do. Control high blood pressure, cholesterol, diabetes, stop smoking. Possibly, if you got a stent, possibly maintain the medications that we put you on, like aspirin and Plavix. You need to be on those medications to make sure the stent doesn't cause any problems in and of itself. So all these interventions will make a difference. Exercise, of course, very important, right? Any exercise is good, but don't wait to start exercising after you've had the stroke. Of course, if you've never done it before, do it at that time. But for the younger listeners, every day matters, and the earlier you do it, the better the outcomes in the long term.
And these last two questions, because we're short on time.
All right.
But it also
Let's do it fast.
It also will lead into something I want to close with that we
Okay.
did very exciting.
Okay.
In the last past few weeks. What are the available options for treatment, which you already explained, but how do they compare in terms of effectiveness and risk? And I'm going to tie this into it. Are there any recent advancements or emerging treatments that I should consider or inquire about?
Right, and I think this is very much on the endarterectomy versus stent versus TCAR type of question, and these are all very effective interventions, like we discussed before. I would say the decision for which is the appropriate treatment is very individualized, right? So we often do advanced imaging like CT angiography or catheter angiography, going through the groin and taking pictures of those blood vessels, and that will tell us whether you have a lot of calcium in your plaque, which makes it very hard for me to open a stent in there because it's like a rock. Or the blockage is high or is low. That can play into how we decide what type of treatment we will institute. So the treatment is very individualized, right? It's not a blanket statement. These are the three treatment options. What would you like? Sometimes that is the case. Everything is available to you, but often it's the anatomy and the morphology of everything that determines what ends up happening with our intervention. So I think that's important. Now, the newest thing is the transcarotid artery revascularization, the TCAR procedure, and I think it really takes advantage of the most powerful components of the other treatments. So when we have the opportunity to offer the transcarotid artery revascularization, we go with that option, yes.
And we recently did one, or you recently did one
Right.
live for our neurovascular conference.
Yeah, so we have an annual conference for providers, right? And so it's very well attended this year. There were about 300 folks listening in. And it's mainly talks in person, but we decided this year to do a live surgery. And so our team was down at Good Samaritan University Hospital broadcasting into the auditorium, and we were able to demonstrate a transcarotid artery revascularization, which of course, among other things, you can find on our YouTube channel at Stroke and Brain Aneurysm Center. And you can see exactly what the process is of doing this procedure. It's a very effective procedure, and it's like a choreographed dance, I would say, right? I'm blessed to have probably the best team in the world when it comes to these procedures in and outside of the angio suite, and it's worth looking at and listening in and seeing how we work as a team to get that result.
It's fascinating, and it's not too gory for those who don't want the
Not
Halloween
at all.
gore.
Absolutely. Well, and with that, we want to thank everybody for listening in. Javaad, thank you for
Yes, thank you for
gracing us
joining
with your
us.
presence. And if you want to hear more, obviously you can subscribe to our YouTube channel, or you can connect with us through our website, www.strokecarelongisland.com. Thank you.